Sorry, I apologize. I have a little bit of a cold going on right now, but so glad this is virtual for you guys. But welcome. My name is Jackie. I'm a fourth year medical student, and I'm excited to talk to you guys about personality disorders today. I think it's relevant, especially in light of all of this that's been going on recently. I'm sure you guys have seen this in the media. And I think it's pertinent because we've been seeing a lot about personality disorders been talked about in the media today. So hopefully we can clarify some things. And I warn you all, when we did this in my medical school classes, we all went around kind of self-diagnosing with personality disorders. So I warn you not to get too lost in the weeds of diagnosing yourself and your friends and family with anything. But it should be an interesting talk. So we're going to start with the case, move into a physical exam, which you'll see is a little bit different for psych patients. We'll go into a differential diagnosis, develop an assessment and plan, and then we'll talk a little bit about personality disorders as a whole. So I encourage you all to actively participate. I won't be calling on anyone in the audience, but I will be posing questions regularly. So I encourage you to either send your responses in the chat or feel free to directly message me if you're uncomfortable sharing with the group. I'll be checking the chat periodically throughout the presentation. So without further ado, sorry guys, let's start with the SOAP note. So I like to do a quick review of what a SOAP note is, just in case there's anyone new here who maybe hasn't done it before. I promise you'll be using SOAP notes as you hopefully come into the medical field in whatever way you plan to do that. So let's just go through quickly. Who can tell me what belongs in the subjective portion of the SOAP note? Exactly, Emily. So these are going to be things that the patient tells you subjectively. So any symptoms, if they say I'm coming in with chest pain would go into the subjective. If they say I have no nausea, that as well would go in the subjective. Now, objective, on the other hand, are things that we can measure. So as you can see here, that would be vital signs, the physical exam, any labs or imaging would go in objective. And then together we will develop the assessment and plan. All right, so we're going to talk about the case details. So we have Miss James, who is a 25-year-old female. She's presenting to the ED with her boyfriend after she cut her forearms with a knife. She has had multiple visits to the ED in the past with self-inflicted wounds. She claims her boyfriend is the, quote, worst person in the world. As a side note, whenever we put something in quotes like this in a note, that means it came directly from the patient in exactly this phrasing. We like to do this because sometimes that can help lead us more towards a diagnosis rather than paraphrasing into our own words, which is especially important in psychiatry to see exactly how the patient described it. So she and her boyfriend have broken up 20 times in the past 6 months. Yikes. Her boyfriend claims that she is prone to outbursts of physical aggression as well as mood swings, which last several hours and can vary from a state of exuberance, which is super elevated mood, and self-confidence to self-doubt. So someone give me a thumbs up in the chat when you're done with putting this in your SOAP note, and we will move on. All right, so you're definitely jumping ahead, but absolutely that's a great thing to put on a differential diagnosis, and we'll be talking about that as we go on. So what questions would you like to ask Miss James now that she's in the ED? She's here with her boyfriend. What do you want to ask? What's important? What's pertinent?
Do her habits changed, or have they changed recently? Does the amount that she eats or drinks change?
Sure.
Changed.
Sure. And what might you be pointing at and asking about, like things like appetite?
I guess that like maybe her appetite may change, so that like she might have depression or she might be mania.
Okay, good, good. Yep. So definitely asking about appetite is important. A lot of times people with depression or in depressive episodes will have kind of anorexia, meaning that they're not eating. Adam, this is super important. Is she working? Meaning, is she kind of like doing anything with her time? Is she able to hold a job? Super important question to ask for psych. So I'll tell you that she is in the process of applying to law school at the moment. No changes in appetite. Mark is asking if there's any new medications. This is so awesome to ask. Absolutely. So many medications have side effects that can affect mood. And so, no, she hasn't started any new medications recently, but that's a great question. And then Emily, what about the family history is important? What specifically would you ask about the family history? Phil, this is great, really important. Asking, was she attempting suicide? We absolutely need to be very clear about this. She came in with cuts on the arm. Was that in an attempt to kill herself, or was that just kind of an attention-seeking behavior? Super important to ask. I'll tell you that the patient, quote, wants to end her life. And that's directly from the patient. Great question. Any family members with psychiatric diagnoses? Absolutely, we want to ask this. This is kind of a nature versus nurture argument for a lot of psych patients, but super duper if they're like, was schizophrenia in the family or something like that, certainly the risk would go up in her. So I'll tell you, she doesn't know of any psych history in her family. Great question though. Anything else? How was her childhood? Adam, this is an amazing question. Absolutely, especially since she's so young. But certainly in any psych patient, we want to know how the childhood was. Unstable homes, any perhaps like sexual abuse as a child absolutely increases risk for the development of psychiatric conditions. I'll tell you, she says her childhood was fine. Stable house, 2 parents, not divorced. She went all the way through school. She's now applying to law school. She doesn't remember anything traumatic from her childhood, but absolutely we ask that of psych patients for sure. Anything else? Or even questions you might want to ask the boyfriend. Maybe he came in with her to be ED as well. So we're able to pull him aside if you have any questions for him as well.
I guess, has her friend group changed? Is she more outgoing or more reserved?
Sure. So asking maybe, is she around new people, maybe potentially being influenced by different people's behavior, new environments, new substances, perhaps. And then asking about, again, mood symptoms. Adam, absolutely. You want to know who's initiating the breakup? I'll tell you, it's usually her. She's usually kind of in a fit of rage, will sometimes get physically aggressive, and she'll rapidly end the relationship. And then within a couple of days, she'll kind of come back and try to reinitiate the relationship. Great question. So here's some questions that I had come up with that I might want to ask the patient or the boyfriend. I want to ask about substance use for sure. Maybe we had talked about this a little bit. How do we characterize a state of exuberance? Can we call it mania? Mania has specific criteria. So, and these are some of them: impulse spending, risky behavior. Impulse spending could be last weekend, she didn't sleep more than 2 hours in 5 days, quit her job, and bought a Ferrari or something. That would be kind of a manic type episode. I'll tell you, she doesn't have any of those. She's been sleeping fine, no risky behaviors. They mentioned that sometimes she gets into these episodes of self-doubt, again, asking, what is that depression like? How is her appetite? How is her focus? Is she still interested in her daily activities? Things like that to ask for sure. And then you guys took it a step further to ask about kind of any suicide attempts or any thoughts of suicide, which is super important to ask. We want to ask about family history of mental illness, as was mentioned by you guys. Amazing. We'd like to know if she's been hospitalized before for sure, especially for psychiatric conditions, but really any hospitalization is important. And any history of incarceration and illegal troubles. Has she ever been maybe for shoplifting or for theft, or she gets kind of physically aggressive with her boyfriend? Has she ever assaulted anyone else? So we're going to take a brief break from the case to talk a little bit about the physical exam for a psych patient. So in a psych patient, we don't do necessarily the full kind of look in the throat, listen to the heart. We don't really do that with psych patients. We do what's called the mental status exam instead. And there are these different kind of components to it. And so the psych quote physical exam is going to be more of a paragraph kind of describing all of these things. So we start with appearance and behavior. So just how does the patient look sitting in front of you? Is she distressed? Does it look like she hasn't showered? Does she look older or younger than her stated age? Some patients come in and lie about their age. I had a patient come into the ED once who was like easily 45 and she was like, I'm 18. And that was not true. So did they look their stated age? Have they been showering? Any like odd piercings, tattoos, hair, kind of flamboyant dressing is important to ask. Then we want to ask about behavior. Is she slumped? Is she kind of, her eyes are darting around? Does she look kind of, what is her behavior like? Is she making good eye contact? Sensorium and cognition are going to be kind of, we hear about this alert and oriented. Does she know where she is, what year it is, what her name is? We want to ask all of those questions to orient her. We want to know, sometimes patients come in and they're completely zonked out. Is she even conscious? How is their memory? Is their fund of knowledge? If I asked her a question and then 5 minutes later asked her the same question, would she answer it like it was brand new? Or would she be like, or would she kind of seem like she had just forgotten what I had asked? Mood and affect. So for mood, sorry, we always use the patient's own words. So as a person interviewing someone in a psych ward, you would say kind of, how are you feeling today? And her exact phrasing might be like, this is the worst day of my life. I feel terrible. We would put for mood, quote, I feel terrible. Affect is going to be, is it kind of really like showing a ton of emotion? Is it really constricted where she's like kind of flat and kind of keeping to herself? How's her speech? Is she talking really fast, really slow, loud, quietly? All of these things can kind of lean towards different psychiatric diagnoses. How is her flow of thoughts? Is she jumping rapidly from thought to thought, or can you follow her story? Does it make sense? And then what is she thinking about? Is she kind of perseverating about, really kind of morbid topics, or is she talking about, some conspiracy theory that she has? All of these things might be kind of a delusional disorder, or could be kind of characterizing a depressive episode, depending on what she's really thinking about. Then we want to ask about hallucinations. They can be visual, tactile, meaning you're feeling like, say, bugs crawling on your skin, or auditory. And then insight and judgment. So for insight, we're asking the patient, do you know why you're here? Do you know why you're being admitted to the psych unit? Do you understand kind of why you're in this position? And if they're like, no, I'm completely fine and healthy, like, I don't know why I'm here, that would be poor insight. And then for judgment, we might ask a question like, if you smell smoke in a crowded movie theater, what would you do with that? And if a patient is like, I would, start to break dance in the middle of the movie theater, that's poor judgment. But if they're like, I would call the police, or I would pull the fire alarm, or I would say fire, that would be good judgment. So now this is for the patient. We're asking, so she is well groomed. So this is what will go in your objective physical exam for this patient. So she's well groomed, tearful. She appears her stated age and she's making good eye contact. She's alert and oriented ×4. Does anyone know what that means? Person, place, time, situation, exactly. So she's completely oriented, which is great, and she has an appropriate fund of knowledge. And as she says, she feels awful, and she's got kind of an exaggerated range of emotion, excessively tearful, excessively angry. Her speech is loud and pressured meaning that it kind of feels like the words are coming out, too quickly for her to even say them all. So she's talking very fast and very loud. That process is linear, meaning that her sentences make sense from one to one to one. She's not kind of jumping around from thought to thought. Thought content, she says she wants to die. Someone had asked earlier, what did she cut herself in a suicide attempt? So according to her, yes, she did. She was attempting suicide. Perceptual disturbances, she says she has no hallucinations. And as far as her judgment, her insight is impaired. She doesn't really understand why she had to come to the emergency room. She thought it was just a normal fight with her boyfriend, but her judgment is intact. So someone let me know when we're ready to move on. I don't want to move too fast or too slow. Let me know if I need to pick up the pace or slow down. Are we good? I can always swing back at the end too, guys. Awesome. Thank you, Adam. So here's a little bit more about our history. This is, we're jumping around a little bit, but this is going to go back up in the subjective part of the SOAP note. So she has been admitted actually 4 times for similar things. She has superficial cuts on the arm always in a suicide attempt, according to her. At each admission, they said, you really need to do outpatient therapy, meaning not in the hospital. And that's what they recommended, but the patient didn't follow up. So she never actually ended up going to therapy, but she's never been hospitalized or like kept involuntarily in the hospital. And she's never received a formal psychiatric diagnosis. So she's not even, according to her, she's not even really sure why she had to go to the hospital so many times. She has frequent headaches, no surgeries, takes no meds. She uses marijuana socially, drinks 4 to 5 beers on the weekends, no illicit drug use, no tobacco use. She has no legal history. She is a college graduate. She's applying to law school. She has been living with her boyfriend for 4 years. And her childhood history, she does report a history of assault in childhood. I apologize. I think I misspoke earlier when I was answering questions. Let me know when we're ready to move on. I know this is a lot of information. Good to go. Awesome. Thanks, Mark. All right, so why don't you guys start spitballing some diagnoses we'd like to consider? I know someone earlier had already mentioned BPD, which is borderline personality disorder, or perhaps you meant bipolar disorder. I'm not sure. But both of those can certainly go in the differential diagnosis. Anything else? Major depressive disorder, absolutely, for the suicide attempt. Anything else? There are no wrong answers. We're just spitballing personality. Yeah, absolutely. I think that's going to be very high on the differential for sure. And we'll talk about all the subcategories of each. Anything else? Anything, any other diagnoses? Doesn't necessarily have to be a psychiatric diagnosis. Dependent personality disorder? Yeah, I think that that's a great one to put up there. Perhaps dependent. Seems like she's kind of going back and forth with her boyfriend. That's a great thought. Absolutely. So here are some ones that I had put. I'm kind of stratifying them into personality disorder, mood disorders, and then just normal behavior. Perhaps she's doesn't have a formal diagnosis and she's just behaving normally. I think this is probably not it. I think that she's behaving very abnormally. So I'm going to say she's probably cluster B, and we'll talk about each of the clusters in a moment. But those include borderline, histrionic, and narcissistic. I think that's probably more so where she falls, just because she's being quite dramatic. Mood disorders include depression and bipolar. So this is some of those questions we were asking about. How's your appetite? Are you still interested in the normal things that make you happy? And for bipolar, we're asking about manic episodes, what characterizes them. So again, any impulse spending, risky behavior, not sleeping for days on end. So she didn't really seem to have any of the hallmark symptoms of these aside from the suicide attempt, which is kind of unclear. If she was really trying to kill herself, she had very superficial cuts on the arm. And you'll see that that's kind of pathognomonic for kind of the highest thing on the differential, which I think was mentioned already. So for her assessment and plan, this is the finishing up part of your SOAP note. For her suicidal ideations, the first thing we have to do, as you guys mentioned, is to assess for intent and plan. So we're saying, do you intend to kill yourself now? And we're asking, did you have a plan to kill yourself? If she's like, no, I just want to die. Or if she's like, yeah, I was going to do it Tuesday at 2 p.m. and I was going to use a rope, or I was going to drive my car off the highway on my way to work. Those two things would be approached a little differently because one shows kind of more pre-planning and the other might, we don't want to take risks, obviously, and assume that they're bluffing, which is not at all what I'm trying to say, but we want to characterize kind of how detailed was that plan. and kind of how much do we reasonably think they were going to follow through with it. Oftentimes we will involuntarily hold these patients. In Florida, we have what's called the Baker Act. It varies per state what it's called, but it basically is an involuntary holding of people who pose a threat to either themselves or others. We can involuntarily hold them in the hospital for up to 48 hours so that they can be assessed by a psychiatrist because they pose a threat. So we might Baker Act her if we were in Florida, for instance, and involuntarily hold her for these suicidal ideations. Then, of course, we will consult psychiatry, which is us today, and we're going to look for probably mood disorder, which again is bipolar depression usually, versus a personality disorder. And then I'd like to do a urine tox screen on her. Someone mentioned substances. She's behaving kind of erratically. Maybe she said no cocaine, but she's super on cocaine right now. So now we're going to jump into the fun stuff. So let's talk a little bit about what is a personality disorder. So this is pervasive, inflexible, and maladaptive, leads to significant distress or functional impairment. So I put this in big blue text because it's important to distinguish personality disorders from just normal behavior. So again, these are inflexible, meaning it doesn't really come and go with time. It's kind of always just a part of who you are. It's a part of how you interact. Dare I say, a part of your personality. It's maladaptive and it causes significant distress. So if she was kind of just a dramatic, it's the difference between having a friend who's just dramatic and having a friend with a personality disorder. And I'm sure we all have dramatic friends. Maybe you are the dramatic friend, but hopefully you don't have a personality disorder that is maladaptive and causing significant distress or functional impairment in your life. So usually they're going to come up during adolescence. So she's in her mid-20s. So perhaps she started showing signs of this earlier. She's been with her boyfriend now for 4 years. So perhaps she was already showing signs in her late adolescence. They're very hard to treat, unlike with depression, which you can usually give antidepressants for in addition to therapy, or mood disorders where you can give mood stabilizing drugs like lithium. We don't usually treat these personality disorders with medication. Typically, the treatment's going to be more therapy-based, which is why they're very, very tricky to manage because we can't just kind of give them a medication to help. They kind of have to help themselves. And so again, it causes significant impairment, sometimes occupational functioning. Someone had asked earlier, is she working? So important to ask because a lot of times people with these personality disorders, as with many psychiatric conditions, have trouble keeping work because they're kind of difficult to work with. And then they're at higher risk for developing other disorders too. So just because she might have a personality disorder, which is that's what we're going to run with today, she could develop depression. She could develop anxiety. She could develop bipolar disorder down the line. It's not necessarily mutually exclusive that she can only have a personality disorder. So now we come back to this lovely lady. I'm sure we've all seen her before. And we're going to talk about some clusters. So there are 3 clusters of personality disorders, A, B, and C. I don't know why I put an E here. This is supposed to just say odd. So typically the cluster A's we characterize as kind of like your eccentric neighbor or like your weird wine aunt who wears really eccentric clothes. These patients will classically kind of just be kind of odd to be around, not quite right. It's not, and so then the main ones that are going to be here are paranoid, schizoid, and schizotypal. And we're going to talk through each of these, so don't worry too much about memorizing all of them on this slide. But these are going to be kind of our odd eccentric people, but it's not fully psychosis, meaning it's not schizophrenia. I know that these all start with schizo, but these are not to be confused with schizophrenia. It's not a subset of schizophrenia. It's not another name for it. Schizophrenia is a fully different diagnosis. So there's no psychosis, no hallucinations. They're going to have a very difficult time forming interpersonal relationships. They may be a bit eccentric and kind of strange. Cluster B is going to be these dramatic people, which if you remember, we put that kind of on the assessment and plan as we think she's probably more cluster B without giving any specific diagnosis. So these are going to be your kind of erratic, very kind of label, emotional, cry at the drop of a hat, very dramatic, the world is ending, oh my God, I can't believe it, my life is over type of people. So these are going to be your borderline, histrionic, antisocial, and narcissistic folks. Cluster C, these are our scared people. So they're going to be fearful, avoidant, anxious. Someone had thrown out dependent personality disorder. That would for sure go in here. So they may also be avoidant. Or we have obsessive compulsive. This is not to be confused with obsessive compulsive disorder. This is obsessive compulsive personality disorder. Again, an important distinguishing feature. Obsessive compulsive disorder is much more severe, and that one we can treat with medication. Again, we don't usually treat these guys with medication. So this is going to be slightly different, and also they're going to function a little bit better than our OCD patients. So let's talk about cluster A in a little more detail. So these patients are odd, just as a rule. They're going to be a little strange. And so first of all, we have paranoid people. So they're going to have pervasive distrust of others. Very suspicious, kind of always feeling like they're being attacked by people. And they might feel like everyone's talking about them. So these people who are kind of overly paranoid. How fault is validation? That's a great question. I think a lot of times they kind of go hand in hand, and they kind of self-perpetuate. Because if you have a personality disorder, sometimes as a coping mechanism, oftentimes these people, again, don't function very well. So as a way to cope, they may turn to substances, and then those substances may exacerbate personality disorders. For instance, if I was already kind of one of these dramatic type cluster B people, and then I drink, maybe I get extremely violent when I'm drunk. And then because I'm so miserable because I made my life bad by acting dramatically when I was drunk, now I need to drink to take the pain away. And then it all just kind of snowballs down. So those would be two separate diagnoses, but absolutely they can both kind of come together, and they can kind of make each other worse, if that makes sense. But substance use disorder would be a separate diagnosis if someone were to have that on top of perhaps a personality disorder. I hope that makes sense. So now we have schizoid versus schizotypal. I've always had a hard time remembering the difference here. So schizoid is going to be these people who are kind of, they're kind of like the loners, like they like to be alone. They kind of don't really care to maintain friendships. Doesn't really bother them that they don't have friends. They kind of like solitary activities, things that don't involve interaction with other people, voluntary detachment. And that's an important distinguishing feature from what we'll talk about in cluster C, which is where they have no friends, but it's they want to have friends. These guys have no friends, but they don't really care to. Schizotypal. Now these, I remember it because typal is like, no, my memory thing is not going to work for other people. I'm realizing that I'm a little odd myself. So schizotypal is they're going to be kind of these eccentric, weird kind of wine ant people who just a lot of times they'll come in kind of flamboyant outfits, looking a little strange, like the people who would you'd see them in like Times Square in New York, and you'd be like, oh, like that's interesting. Those kinds of people. They'll have what's called magical thinking, which means that they'll be like, oh, I heard a door close behind my left ear the other day, and that means that it's going to rain tomorrow. So kind of thinking that things are related maybe when they aren't, or that thoughts are able to control reality, meaning like if I think really hard, kind of like taking, when people say like, I'm going to manifest this, taking that to an extreme. So these people are going to have few or no close friends because they're a little strange, because I think people find this behavior a little off-putting a lot of the time. And they'll have some social anxiety, and they'll often prefer social isolation because they're a bit paranoid. So as you're probably starting to see here, a lot of these things are kind of starting to overlap, which is why oftentimes you'll see in psych, they won't necessarily give a specific diagnosis. They might just say this person is kind of got cluster A traits, meaning that they've got kind of a mix of these things, which is a bit of a cop-out, but it's kind of what I like to go with if I feel like it doesn't necessarily neatly fit into one. So we're going to do a quick exercise after each of these, and I want you guys to brainstorm out of these guys, paranoid, schizoid, and schizotypal. What do we think Gollum would be if we had to diagnose him if he came into the ED? Schizotypal. All right, we got one for schizotypal. Why do you say schizotypal, if you don't mind my asking? And also, if anyone else has other diagnoses, by all means. And if you have a non-personality disorder, you never saw the movies. Oh no. So this is the guy who was like, "Hi, precious," with the ring. And he's kind of like, I'm really sorry. So we're going to do some movies. I tried to pick popular ones. But I'm sorry if you haven't seen them before. So this guy's, I also actually haven't seen the movies, but I've just seen him and I feel like he fits into one of them. So now you're thinking schizoid because he is a loner. Yeah, he kind of like lives in a cave, I think, by himself. Any other proposed diagnoses for him? Paranoid, constantly scared. Yeah, no, for sure, for sure. So I had that thought initially too of like, he's really nervous all the time. This guy is for sure, I would say, like cluster A. And then I think it's actually kind of tricky to give him a specific diagnosis. I completely agree with the paranoid. I also agree with the schizoid. So I would call him cluster A traits. And I would say he's probably a mix between the two of these. And so, Sammy, I think you bring up an interesting point of like, it not necessarily schizotypal. He's not super eccentric. I mean, he's got no hair and he looks a little strange, but not necessarily eccentric. I might call someone like Dumbledore kind of a little bit eccentric. Not that Dumbledore would be schizotypal, but that might be like a more flamboyant person. So now let's talk about B. We call it these the bad ones because these are dramatic, emotional, and erratic. And we have these four. So borderline is the one that's been coming up in the media a lot. We've been associating this one with Miss Amber Heard, has been kind of thrown around as a diagnosis for her. So this is characterized by unstable mood, intense anger, sometimes self-damaging acts. You mentioned substance abuse. So again, sometimes they'll do this kind of to almost self-sabotage their situation. Self-harm, suicidal behavior, very suspicious, unstable personal relationships, and fear of abandonment. So, and a lot of times these patients will have history. We had asked this patient about her childhood. Many times these patients will develop this disorder from perhaps sexual trauma in childhood or just kind of very traumatic, withdrawn parents in childhood. Is a very common risk factor for this. So borderline is kind of these very, very dramatic, black or white, yes or no, live or die types of people. Now we have histrionic. You may have heard people be like, describing someone as being histrionic. This word actually comes from Freud, who described his female patients with anxiety as being histrionic. The definition has since changed because Freud is a little problematic. But histrionic we use for like attention seeking. So that's a little different than this. Borderline's got some attention seeking features to it, but histrionic's going to be a little bit more like maybe wearing very provocative clothing, trying to like peacocking, like those people who will wear like the big boots and the big hat and like a huge rhinestone belt, perhaps trying to like attention seek, very dramatic speech, kind of emotional, exaggerated emotional expression, and kind of needing to be the center of attention. So I think of histrionic as like those people who will throw a fit if you're not talking about them, or if you try to be like, oh, my weekend was good, they'll be like, well, my weekend was way worse than yours, you have no idea. And kind of that like one-upmanship in conversation where they kind of always have to talk about themselves. So again, these people may be kind of inappropriate, provocative, overly seductive with others, just kind of really trying to get attention wherever they can. And these might also be the people who are like, you met them 5 minutes ago and they're like, oh, good, like now we're best friends. Not a good way to be. Antisocial. So this one is not really an intuitive definition. Antisocial is what we associate with like psychopaths. Oftentimes people like Ted Bundy, for instance, would be considered an antisocial personality disorder. So this is characterized by deceit, manipulation, hostility, criminal activity, reckless, lack of remorse, emotional indifference. So many like serial killers will be diagnosed with this. This is a huge field of study. A ton of like criminal lawyers when they interact with psych and psychiatry. This is kind of much of what they deal with for a lot of these very violent criminals. And so these are the people who you'll interview them and they'll be like, yeah, I don't feel bad about killing that man. I did it because it made me feel good. So that's these people, very dangerous. Narcissistic personality disorder. This word gets thrown around a lot, but these are people who have an excessive sense of self-importance. They're going to exaggerate their achievements. Like say they got a promotion, they'll be like, well, it's because I work harder, do more, and am better than everyone else in the office. And so they would be an idiot to not give me a promotion because I'm better than everyone. And that's a little different than histrionic because it's going to be less like this conversation needs to center around me. This is more like I think and feel that I'm better than everyone else. So they're going to feel kind of just superior in every way to the people around them. And they're going to expect favorable treatment. Why can't I go to the front of the line? I'm me. Why should I have to wait in this line? I don't deserve to wait in this line. I'm better than everyone else. And kind of similar to antisocial, these people may exploit others to achieve their goals because they feel it's kind of their birthright to achieve more, do better than others. And they're not afraid to step on other people to get there. So now let's talk about some people on this slide. I hope you know at least a couple of these. So let's start with Peter Pan over here. What would we want to diagnose Peter Pan with? Anyone?
Yeah, I say histrionic, a bit over the top.
Okay. Yeah, maybe histrionic. I mean, he is kind of a dramatic fellow. Look at this hat. Yeah, Adam, I definitely agree with you. So this is Joe from the show You. I would definitely say antisocial for him. So for Peter Pan, I said narcissistic, just because I feel like much of his narrative is kind of I'm better than the other children. I'm kind of living a little bit above kind of everyone else around me. I'm like kind of doing the lost boy thing better than everyone else. I'm above childhood. I'm above growing up. I for sure said that this guy was antisocial. He like murders people. I hope that's not a spoiler. For sure, antisocial. And again, I think this character is important. I hope you guys are at least familiar with the show if you haven't seen it. He's very charismatic. He's very good looking. I think that this is kind of similar to like the Ted Bundy thing where he was very charismatic. People really liked him. He won people over with his charm and his looks. But inside he was kind of lacked empathy for those around him. For Zoolander, I said histrionic, but I think also narcissistic could for sure work for him. He's very kind of dramatic and kind of overly dramatic. So I would say agreeing with you about the narcissistic. Now let's talk about, I don't know if you've seen Silver Linings Playbook. How about Tiffany from Silver Linings Playbook, if anyone has seen it? This character actually in the movie had a diagnosis of bipolar disorder. But Tiffany has a slightly different diagnosis. If anyone has seen it. If you haven't seen it, I apologize for the obscure movie references. Yeah, exactly. So she has borderline personality disorder. She kind of has erratic, sometimes risky behaviors. She has kind of rapid mood swings, where this guy is either like the best guy in the world, or he's awful trash. I'm done with you. I'm going to dump you tomorrow. And that's kind of very classically borderline. So I put that for her. Now let's talk about cluster C. So these are kind of our scared people. We have avoidant, which is kind of like you can't lose the race if you don't start, right? So these are the people who may not engage with other people because they're afraid of being rejected. So I had kind of compare contrasted this with schizoid earlier in the cluster A's, because schizoid people don't care to have friends and they have no friends. These avoidant people would really like to have friends, but they're kind of so afraid of being rejected that they often don't have very many. dependent personality disorder was mentioned for this patient. And I think that it's a good thing to throw out there. So these are people who kind of can't be on their own. They can't make decisions for themselves. They always have to check with someone else. They can't initiate things. And it kind of all comes down to a lack of confidence. Just, I'm not really confident that I could stand on my own 2 feet and do this for myself. So I'm sure we all have that friend who, once they're not in a relationship anymore, rapidly starts, another relationship, which is, again, is not necessarily a personality disorder. I'm just using it as an example. Don't diagnose your friends. But very fearful of being abandoned, very fearful of being on their own, really dependent on the other people around them. Now, OCPD, again, different than obsessive compulsive disorder. These people are very concerned with rules, lists, order, keeping things, being productive. So sometimes these people will thrive very well. You'll find yourself, this is what I diagnosed myself with in medical school. And I think you'll find that if you are planning to go to medical school, you'll find that much of your class is probably OCPD. Many of us like lists. Many of us like kind of are perfection driven. Sometimes difficulty delegating work. I'm kind of reading myself here, but difficulty delegating work, difficulty collaborating with people occasionally because it's my way or the highway. I'm going to do this project. I'm going to lead the project. And then it gets to personality disorder rather than just being kind of like a type A organized person, when it becomes kind of inflexible. So now you're in a group project and you say, no, we need it to be a PowerPoint. And everyone is like, no, I don't want to do a PowerPoint. Let's just do an oral presentation. And you're like, no, it has to be a PowerPoint or I'm quitting the group project. That would be a little bit more OCPD, where it's kind of like rigidly unflexible, kind of my way or the highway. Anyone got any diagnoses for these folks? Yeah, I think they're both kind of OCPD. So for those of you who've seen Harry Potter or know of it, Hermione Granger is kind of like this bookworm. She's very rigid in her routines. And that's one of the things that we love about her, but also can be a little inflexible in the way that she is, especially kind of earlier in the series. Kind of very rigidly dedicated to order, school. Her worst fear is being expelled. Sheldon Cooper. This is kind of a controversial one because I think he might also fall a little bit on the autism spectrum, perhaps. But again, not mutually exclusive with personality disorder. I think he's also a little obsessive compulsive. He has to knock 3 times before going to his neighbor's door. Things like that are kind of obsessive compulsive type tendencies. So now that we've gone through the personality disorders, I thought we'd revisit the case and talk a little bit about, now kind of that we've gone through it, what stands out to you here? What would you highlight? What's important about this for trying to get towards our diagnosis? The outbursts seem kind of borderline. I agree. These outbursts of physical aggression and the mood swings, for sure. Anything else? Worst person in the world? Yep. Yes, absolutely, Cole. I agree with you. Being kind of very black and white about it. Like, worst person in the world is a very black and white statement. So these are the things that I kind of picked out. So I said she cut her forearms with a knife. I wish I had put here superficial cuts because I think that's important, versus people who are making usually kind of a more dedicated is not the word I want to use, but people who are truly attempting suicide will usually make much deeper cuts, or they'll attempt suicide in a different way. Oftentimes these borderline patients will come in with like almost like scratches on the arm, where you can kind of tell it wasn't a true suicide attempt. It was more of kind of like a kind of just a dramatic attention seeking type thing. Multiple visits to the ED for the same thing. Again, just kind of repeating patterns. You had mentioned worst person in the world. Absolutely. It's kind of a very dramatic thing to say. 20 times breaking up is insane. outbursts of physical aggression for sure. And she's got this kind of self-confidence to self-doubt. I put again here some of these criteria for borderline, just so you can kind of compare contrast kind of what she has. So sorry guys, versus what is in the criteria. So she's got this unstable mood, very difficult anger. She's got some kind of self-damaging acts. Just because they're superficial cuts does not mean that it's not very urgent and severe, that she's even gone so far as to attempt suicide, or even start to try to attempt suicide and use that kind of as a almost like a threat to her partner, it seems. She's suspicious probably because she's got all this self-doubt. They've broken up 20 times. We're not really sure why they've broken up 20 times, but that's often due to like, well, I thought he was cheating on me, so we had to break up, and then we got back together when I realized he wasn't. So sometimes a little paranoid, unstable personal relationships. Again, this has been an unstable relationship with the two of them, and fear of abandonment. Oftentimes they'll come back and they'll kind of try to find friends anywhere that they can. So we're seeing here already some overlap with other things. We're seeing some paranoid overlap. We're seeing some fear of abandonment, maybe a little avoidant. So we're seeing overlap with other conditions, but predominantly this would be for sure borderline. So I mentioned that there's usually not medication treatment for these personality disorders. Oftentimes it's going to be therapy based. So for borderline, there's a very specific type of therapy that we do called dialectical behavioral therapy. So this is going to focus on relaxation techniques, how to reduce kind of these unhealthy self-destructive behaviors. And so this would have to be something that the patient would have to be willing to do, which is why these are so kind of insidious in trying to diagnose them and treat them. Because again, just diagnosing someone with diagnosing this woman with a personality disorder may set her off even more and may make her further resistant to therapy. If we're like, hey man, like you have borderline personality disorder, she might be like, what? How dare you? You're the worst doctor in the world. And totally refuse therapy. So there's kind of a balance between I mean, obviously not hiding things from the patient, but also saying things in a way that's going to hopefully encourage them to seek treatment. So we're going to focus a lot on mindfulness with her, kind of what's happening in the now, not getting lost in kind of these thoughts or maybe paranoid thoughts or kind of self-doubt thoughts, and just kind of staying in the moment, regulating one's emotions when she's feeling like she's about to have an emotional outburst, kind of self-reflecting and thinking about what's causing this. Is this rational? Distress tolerance again. Maybe the boyfriend comes home late from work, managing the distress, not, immediately jumping to, well, I'm sure he's off, on a date with someone, and kind of managing the distress that she might be feeling. And then asserting their needs without coming into conflict with others. Again, if she feels like, hey, it's really important for me that we do dinner once a week, not getting into a massive argument and breaking up over it, but kind of being like, hey, let's approach this calmly. So again, as you can see, there's a lot of work that has to be done on the patient's end. And unfortunately, that's the case with most of these personality disorders, even like the antisocial one that we associated with like psychopaths. Oftentimes, again, cannot be medicated. I wish you could give a medication to someone to make them not like a psychopath, but that's kind of one of the arguments for giving counseling to these people who may be incarcerated, et cetera, or kind of getting early therapy to some of these like maybe young adolescents who start showing traits of this prior to diagnosis, like putting those people in therapy early, try to start to manage some of these traits. So here are my sources. I'm sorry that I did so much talking, and I'm sorry that I've been coughing at you all this whole time. I hope that you guys learned something. I hope that this was interesting. I'll stick around and answer any questions that you guys might have about psych, about med school applications, about personality disorders. Let me know if you'd like to see more psych things. I think it's a really interesting topic. Again, I think it's been shown a lot in the media, so I think it's cool that now you guys know a little more than maybe the average person about it. So I'll stick around until the end of the hour, but if not, best of luck with everything. Thank you guys so much for spending time with me. And again, I apologize for my coughing. Oh, I think next week I'm doing orthopedics approach to x-rays. So if you guys want to tune in next week, I probably won't be coughing. I hope you guys can make it. Thank you so much.